Okay, cool. So we'll start. So yeah, anyone that joined last couple of minutes, my name is Nikhil. This is the first part of two teachers, which I've just titled Ophthalmology for the Foundation Doctor. I've just tried to basically reflect and think of times when it would have been more useful to know bits more about ophthalmology, basically. And yeah, I did my foundation training in Stoke, and I'm just doing my F3 here. So learning objectives to cover a key mix of eye cases which may be encountered during acute specialities or GP during the foundation program. It's going to be a real myriad of different cases, so eyelid disorders, eye infections, corneal disease, and just build upon what Mr. Basu is doing in this last lecture and the next lecture. Ophthalmology is very, especially with oculoplastics, you can really see it. So I've included loads of pictures, and I'm going to try and make it as interactive as possible, ask questions, and feel free to ask questions if you, at any point, if you want to clarify anything. And yeah, also just to kind of get you in a position where you feel comfortable to refer common cases to an ophthalmologist. So the first case, you're an FY2 in GP and a 54-year-old male patient says he's had this red bump on his eye for the last 2 months. It started off as red and painful, but the pain went away after a week. The bump is painless with no other eye examination findings. What's the most likely diagnosis? And feel free just to guess. Like there's no pressure or anything. This is like for learning. It's not like you've done or doing your final, so it's not to do with that. It's just about trying to think about things it could be.
Could it be that the tear duct is blocked?
Yes, that is actually not too dissimilar. That is something we're going to cover as well. And all these pathologies, they're really, really similar because they're all around the same sort of place. Do you know, so the tear ducts, there's tear ducts. Can you see my mouse as well on the screen?
Yeah, we can.
Okay, cool. So you've got the lacrimal gland, which is the superolateral part of the eye, and then you've got the lacrimal duct, which kind of comes here. This is inside the eyelid, and what lies inside here is the meibomium glands. So this thing is basically inflammation of the meibomium gland, and I'll give you a clue, so we'll make it like multiple choice. It's either going to be a sty or a chalazion. Any guesses which one it could be?
A chalazion?
Yes, exactly. It's a chalazion. So a chalazion is also called a chronic internal sterile granulomatous reaction of the meibomium gland. Does anyone know what the meibomium gland is? So no worries if you don't. This is not something that I would have known like in medical school without like actually specifically looking it up. So it's basically a special type of sebaceous gland that secretes a substance called meibum, which is similar to sebum as in sebaceous glands. And meibum is the lipid portion of the tear film when someone has a tear. And what happens in a chalazion is that the meibomium gland gets blocked. So then all this meibum, this like fatty fluid, extravasates into the eyelid tissues, and then there's an associated inflammation as well. And with this little bit of inflammation and the fat, that's when you get this kind of chronic appearance of this kind of lump that starts off with a little bit of pain, but it becomes painless. And importantly, there shouldn't be any ulceration, bleeding, or telangiectasia, because this could be things like a squamous cell carcinoma or a basal cell carcinoma. You have patients come to GP and they'll have a lump, and you might think it's a chalazion, but it's just important to rule those things out or refer people if you're worried. So to treat it, you might remember this from medical school, you do things like warm compresses and massage, but I want to make this lecture as kind of practical as possible. Like imagine a patient comes to you and you do a chalazion. It's all well and good saying, oh, warm compresses and massage, but what that actually means is they take like something like a cotton pad and they run it under some hot water, put it on their eye, and then they basically what's called milk the eyelid. So the top eyelid, they kind of go down from superior to inferior, and the bottom eyelid they go up, so inferior to superior, and just effectively milk the eyelid and massage it. Usually it goes away by itself in 2 to 8 weeks. However, you can do surgery if there's visual problems or it's persistent or the patient themselves wants it. rapidly resolve. And in the bottom right picture, you can see the meibomian glands, like these kind of very small, or the openings of the meibomian glands on the bottom eyelid. So it's one of these things that will become a bit, will become blocked, and that's what will lead to this chalazion. So the next pathology is called blepharitis. This is quite common. One of you might have experienced it. It's basically a chronic staph infection of the eyelid margins, and it's often associated with seborrheic dermatitis. So symptoms, as you can see in the eye, it's kind of red, scaly, if you can see a bit there, irritation, burning. You can sometimes get a loss of eyelashes as well, reduced tear film, inflammation of the meibomian gland again. You can see in that bottom picture there's some yellow spots, and conjunctival injections, so you can get the conjunctivitis as well. So as before, you can do warm compresses and some massage, but in this case you can also do some diluted baby shampoo as well. That can help people. And if there's signs of an infection, then you will probably need to give antibiotics. So you can give an extended course of chloramphenicol for six weeks. And it can be a bit of a problem, really. It can kind of become complications like keratitis, conjunctivitis, cellulitis, and it can kind of be an ongoing thing. So it's good to kind of sort it out when it first happens. So a stye is an acute staph infection of the eyelid. And there used to be a big thing in the past about external hordeolum, internal hordeolum, but that doesn't really matter now, for purposes of treatment. So you basically just get what looks like a yellow red spot on the margin of the eyelid, either at the top or the bottom. And it looks a lot like a chalazion. A stye can become a chalazion after time because it can cause the meibomian gland to be blocked. But in the acute phase, it's much more tender, it's much more red, it looks much more inflamed, basically. So again, lid hygiene, massage, and warm compress. But you don't really give antibiotics unless you think there's a conjunctivitis. It's the kind of question you'll see on PassMed as well, where someone will have a stye, but you don't give them antibiotics unless there's evidence of conjunctivitis. And again, the bottom right picture is BCC. I'm not sure if it's easy to appreciate on the screen, but you can see there's some small lines in there, so telangiectasia. So again, it's not something to miss. So the next thing, as one of your colleagues mentioned earlier, is inflammation of the lacrimal gland. So what is the lacrimal gland?
It's the gland responsible for producing tears to not just obviously for crying, but for produces the substance which protects the eye from foreign bodies and whatnot.
Exactly. Yeah. It's an exocrine gland, and it produces the aqueous part of the tear film. So before we talked about the lipid part of the tear film, this is the aqueous part, you've got the lacrimal gland on the bottom, or on the top left, and on the bottom right, you've got where the tears drain into. So on the top bit, you've got the superior canthus, on the bottom bit, you've got the inferior canthus, and then the upper and lower canaliculi are the ducts that drain it, and then that drains into what's called the lacrimal sac, and that drains into the lacrimal duct. So dacryocystitis is inflammation of this lacrimal sac, so this top bit of the drainage system. So you can see this chap has a bit of inflammation on the edge of the bottom part of his eye, the bottom medial part of his eye, and that can become inflamed, and it can become blocked as well. So the signs and symptoms are things like tearing, purulent discharge, tears that won't drain. You can get cellulitis as well because of the obstruction. In the acute phase, you can give oral antibiotics. And again, this is all things to kind of check your local trust guidelines, but generally it's Coamox. And in the chronic phase, again, you can give warm compresses. But if that's not resolving, you can do an ophthalmology referral for probing, which is basically where they just get like a metal probe and kind of stick it into the lacrimal system and just manually try and sort the blockage, or they can have an IND as well. And then similarly, inflammation infection of the lacrimal gland is called dacroadenitis. It's a bit less common. So you can't really appreciate it with the picture, but you see kind of redness and swelling on that bottom, on that top lateral bit, on the upper lid. But also, if you literally if you invert the eyelid and ask them to look down, you can literally see what looks like an inflamed lacrimal gland. It will give the appearance of kind of a superior or lateral mechanical ptosis. Causes are things like infection, bacterial, viral, but also you can get autoimmune causes like sarcoid and Sjogren's. Again, treatment, warm soaks, antibiotics, and again, if it's severe, an opt-out referral for an IND. So the second case, you're the F1 working in CAU or the Children Assessment Unit, and a 7-year-old girl has been brought in with a red, swollen, warm upper right eyelid and is generally feeling unwell. On examination, the lid feels warm as well. Her pupils are equally reactive to light, and extraocular movements are intact, but it's a little bit sore when she's asked to carry out the movements. And she's febrile, her temperature is 38.9. What's the most likely diagnosis?
Would this be orbital cellulitis?
Yes, so it's definitely cellulitis. You can see it in the infection. But one important distinction that I think is really useful to learn today, if you don't take anything else, is the distinction between periorbital and orbital cellulitis. And in this case, actually, it's periorbital cellulitis. So it's also called preseptal cellulitis in some textbooks. And the causes is things like direct inoculation, so someone having like a cut or an insect bite that gets infected from adjacent structures, so things like sinusitis that spreads into the orbit or the tissues that surround it, or also hematogen spread, so someone with a full body sepsis which spreads to the eye as well. So signs and symptoms are things like eyelid edema, normal visual acuity, no proptosis, normal ocular eye movement. So this patient had a little bit of pain, but they weren't screaming in pain. Pupils equally reacted to light and normal color desaturation, and you treat it with antibiotics. And if you can see that picture in the bottom right, you can see there's that blue rim. And what's that showing is the orbital septum. So that's basically like a fibrous tissue layer, which is the main part of the eyelid. But as soon as the orbital septum gets affected anatomically, that is orbital cellulitis. Whereas if it's just on the outside, affecting the skin and the bit of subcutaneous tissue, that's periorbital cellulitis. And this is quite an important distinction because it's the kind of thing where either you admit someone and they might need surgery, or you can send them home with oral antibiotics. So this is the kind of thing that's worth knowing in ED, basically. So orbital cellulitis, it basically just looks much worse. Like you can see in this patient here, like they've got the very severe lid swelling, they've got kind of a violaceous color, they can't even open the eye probably. And if they can't open the eye, then what's going to be quite useful is CT. So you can actually do a CT that kind of demarcates where the infection is, whether there's an abscess. And yeah, the table shows it as well. So you might get proptosis in orbital cellulitis as well because there's so much swelling, it brings the eye forward. Eye movements are very painful. You might have a reduction in visual acuity, color vision, and in severe cases you can also get what's called an RAPD, relative afferent papillary defect. Is that something that Mr. Pursuit covered yesterday?
Yeah, I think in the context of optic nerve.
Perfect. That's good. Okay.
Damages.
Nice. Okay. So I've got an RAPD. Maximum respect and brownie points to the person that can explain it. Or if not, that's not a problem. I can do it as well.
I was going to say, no, I don't think that's gonna happen.
No, that's fair enough. No problem. So it's basically just a bit more subtle than doing like a pupil light reflex, because someone their light might still constrict, but to pick up on more subtle pathologies, which are optic nerve pathologies, it's way better to do a swinging light chest or to check for RAPD. This is the kind of thing you can do as a junior in ED. So the one on the left is a normal eye. So you get your flashlight and you look in that left eye, and as I'm sure you're aware, you've got a direct part of the papillary reflex and the concentric part. So they've shined the light into the right eye, and they've got constriction. And because there's a concentric reflex, the left eye has also constricted as well. And this is someone looking at you. So this is the right eye, this is the left eye. And yeah, that's what happens. So you then go into the left eye, and then again there'll be constriction on both sides, and you're on the right eye. So that's what a normal eye is going to do. Whereas in RAPD, you've got the normal pupils at first, and then you shine the light into the unaffected eye, and you're going to have constriction in that eye and constriction in the other eye. But as soon as you shine it into the other eye, you know, basically it's not going to constrict. It's going to look like it's dilating, which is a bit weird. And it's not really dilating, but what's happening basically is that if you do it kind of regularly, this swinging light test, where you kind of every 2 seconds you bring it to one eye, bring it to the other eye, bring it to the other eye, you're not giving the eye with the pathology time to adjust back to the eye is remaining it's remaining constricted. Let me see if I can explain this the right way around. I don't want to say this wrong. Just to start from the beginning, it's when you shine the light into the eye, it's going to dilate, and because of, I don't know, I don't want to say this wrong, basically. I think the important thing to take away, rather than, I was going to explain the reason for it, but it's a little bit complicated. I might have to look it up and explain to you guys next week. I'm doing a teach for you guys next week as well, just kind of re-clarify these topics. But the takeaway message is that if you shine the light into the affected eye, then it dilates rather than constricts. That's the main thing. And as one of your colleagues mentioned, it can indicate optic nerve pathology. So things like, and I'll tell you, things like optic neuritis is one of them, and also glaucoma, which is like so glaucoma basically just means pathology of the optic nerve. It's commonly, people think it's like intraocular pressure, but that's a bit of a misnomer. You can get it in the presence of normal intraocular pressure. So yeah, things like glaucoma and optic neuritis, you might see an RAPD. So case 3.
Sorry, just before you move on,
yeah.
In terms of sort of practically for doing that, would you obviously, if you're suspicious there's some eye problem, because I presume you'd only really do this if you were thinking that there was some problem with one particularly affected eye. You wouldn't just do this as a, because I'm just thinking for myself, if I would do this, I'd sort of, I don't know, kind of miss it almost. So is it a good idea to sort of focus on the eye, focus your vision on the eye that you think has got the problem? Does that make sense? Sorry.
No. Yeah, basically, exactly. You'd only do it if you think there's a problem. You know, I think for 95% of cases, just doing a normal pupillary reflex will be sufficient to say that there is no eye pathology, because there'll be appropriate constriction. But in cases like, you know, I saw someone with optic neuritis or query optic neuritis earlier this year, you know, and you see them, you know, you don't just see them in ED, you see them in medicine as well, like someone with MS with a bit of an eye problem, and in those cases it's worth just kind of double clarifying, like, is there an RAPD? So just, if you think there's a pathology, then focus on it.
Sure. No, that's great. Thanks.
No worries. So the third case, a 42-year-old male patient presents to his GP with a 2-day history of eye watering, burning, and itching bilaterally. His wife had the same symptoms a week prior, and on examination, there's erythema, moderate chemosis, which is basically just swelling of the conjunctiva, and just erythema. His neck also has some tender pre-auricular lymph nodes. What would you say is the most likely diagnosis?
Conjunctivitis?
Yes, exactly. And if I had to tell you that it's going to be either bacterial, viral, or allergic conjunctivitis, based on the history, what would you say is the most likely one?
Either bacterial or viral.
Yep, that is correct. If you had to hang your hat on one of those.
Bacterial?
Sorry. It's viral. So basically, as I mentioned, conjunctivitis can be bacterial, viral, or allergic. And the symptoms that you get in all of them are gritty, itchy, a foreign body sensation. You get a redness that affects all of the conjunctiva, so the whole white part of the eye looks red, which is quite significant compared to something like anterior uveitis, where you get a bit of redness around the black bit of the pupil, but then not necessarily much more, or, you know, episcleritis, where you get like a little patch of red, but in this case the eye will look pinky reddy all the way across. And in bacterial conjunctivitis you get mucopurulent discharge. So in the history, there would have been like evidence of kind of a pussy kind of discharge as a classical sort of case. They might say the eyes are stuck together. It could also be part of a Reiter's syndrome or reactive arthritis. Does anyone here know what that is?
Is that the can't pee, can't see, can't climb a tree?
Yeah, exactly. So yeah, that the most common cause of that infection is chlamydia. So then you've got viral conjunctivitis. So this is in this history there was kind of a watery discharge. It's far more infectious than the other two as well. So that's why I mentioned a bit about our partner having had it. You have a sore throat and pre-auricular lymphadenopathy. So again, in GP, that might be something you want to examine just to kind of see if you can come to a bit more of what you think might be causing it. You can get blurred vision due to disruption of the tear film, and in very severe cases, you can get corneal involvement as well. And in allergic conjunctivitis, there'll be some evidence of atopy or hay fever symptoms or like seasonal symptoms. So you treat it with chloramphenicol. This is the kind of thing you're going to prescribe loads, like, when you're on F1, F2, like, the consultant will see someone with a red eye and say, oh, it's conjunctivitis, and just tell you to prescribe it. But it's one of those things that's worth kind of knowing. Does anyone know what the full prescription is for chloramphenicol? So basically, it's 1 drop of chloramphenicol QDS for 7 days. And something you can always look up at the BNF if you need to, but it's something which is useful to know. You can give lubricant drops if you've got a viral infection. If you're worried about corneal infiltrates and affected vision and contact ophthalmologists, they can give steroid drops. And also you can give antihistamine drops for allergic, not viral. That's a typo there. And I've just been trying to work out how to cover red eye, because there's so many ways to cover red eye, like mnemonics and like ways to break it down in terms of the symptoms. But once I'm happy with a good way to cover it, I'll do it, and then we'll cover it next time. So yeah, there's another teach of this, like the second part, on the same time on Friday next week. Now this is just a spot diagnosis. So if some patient comes in to GP with an eye like this, they're very worried because it looks quite dramatic. What do you think it is? Okay, so this is a subconjunctival hemorrhage. So it's a precipitance of things like, a bit of trauma can cause it, a sudden rise in intraocular pressure, like lifting, heavy weights. You can get a burst of capillary, like a cough or something can cause it, or rubbing of the eye. And risk factors, things like hypertension or anticoagulant use. And as dramatic as it looks, it is something that will go away, it will resolve. And it kind of goes away the same way a bruise goes away, so it will go like red, and then the colors of a bruise like green and yellow, and it will go away after a few weeks. The important thing is to explore any underlying issues, like if someone's on apixaban or have hypertension, it might be a sign that something else, like they're having these bleeding episodes, and that's what's worth exploring as opposed to the subconjunctival hemorrhage itself. Another spot diagnosis. This one's a little bit harder than the last one. So, in medicine, kind of like break stuff down as well. So you can see like there's what looks, like something here. That's what I think looks abnormal. Any ideas what this is, this stuff? So yeah, that's basically it's blood, and this is basically it's called a hyphema, and it's a bleed in the anterior chamber secondary to an iris vessel rupture. I'll quickly just kind of recap the anatomy. So this whole thing is the posterior chamber, and this is the anterior chamber. So you've got if you've got a bleed of one of the iris vessels, then the blood's gonna form here, and with the gravity of a patient standing up, the blood's gonna pull to the bottom. and the cause of this can be things like, trauma can cause it. So this is kind of like a, significant trauma. Also can happen spontaneously as well. And then complications are basically like the rebleeding being the number one thing. So it starts, with a, it might kind of be as it is, but then as the clot, if the clot doesn't form adequately, then you'll get a way worse hyphema, and then the whole eye, like the fluid will literally go up the eye, and then that's what's called an 8-ball hyphema. So that's what the risk is. And there's a increased risk of glaucoma as well, because I'm sure you can imagine, if you've got more stuff in this anterior chamber, it's going to overall increase the pressure, which could in turn reduce the aqueous fluid being able to leave the eye, so that could cause glaucoma. Corneal staining, so the blood could literally stay there and stain the cornea, which could severely affect someone's vision, and yeah, decrease vision. So yep, that's pretty much that's everything. Any questions about anything?
With the hyphema or the subconjunctival hemorrhage, will the patient feel any pain because of that blood and like an increased pressure in the eye, or will they just notice it because it looks funny?
That's a good question. So if you're having pain in the eye, then that might well be the beginnings of narrow angle glaucoma. So that's what that would indicate if there was pain. And if there was pain, then you'd start by trying to dilate the pupil, giving atropine. You can give topical steroids as well, because if there's blood, it's going to cause like local inflammation. But there shouldn't be pain unless there's like a complication.
Okay, thanks.
No worries. Any other?
Yes, sorry. Can the hyphema look a little bit like sorry, I suppose what I'm saying is there a similar appearance between the hyphema and the anterior uveitis? I think that's what I was sort of thinking you were getting at, that it was that, because I've not actually seen an anterior uveitis.
So I think what you're thinking of actually, something I was going to cover next time. It's called a hypopion. So it literally looks like, so this is basically, it's a layer of red cells. In a hypopion, it's a layer of white cells. So it looks exactly the same, but instead of being red, it's white. And that's a sign of like infection or inflammation. And that's the kind of thing you might see in a severe anterior uveitis.
Oh, okay, cool.
Yeah. Cool. Any other questions? Cool. Well, thank you for listening. And yeah, I'm going to do like a part 2 of this series next week. So yeah, feel free to email me if there's any specific things you want to cover. And yeah, thank you for listening. I think the lady in the office is going to send out a feedback form as well, which will be really useful. I'm applying specialty training this year, so yeah, it'll be really useful if you could just tell me what you think, anything good or anything I could improve. So yeah, thanks. Okay.
Thanks a lot. Cheers.
Thanks. See you.